Okay, without further ado, kita continue lah dengan previous presentation. Okay, dengar kan?
Dengar tak?
Okay, okay.
So, we last stop with, I think the next presenter will be ni Niswa Mucho Okay, so aku buka Kau nak buka kan? Okay, ya.
Okay, good.
Whiteboard.
Whiteboard.
Screen kan? Screen.
Screen. Ini ada whiteboard.
Tak, dia punya ni. Foto.
Apa ni?
Tak. Aku tengah nak cari. Ada. Doctor dependent, cyanotic, cyanotic hepatic disease. Apa nama title korang kasi?
Yang syndrome associated with congenital heart disease. Ada tak?
Okay, good.
Ada. Dekat
yang presentation tu.
Dekat presentation yang ni, betul? Slow. Okay.
Slide number 6 ke? 6 ke 7 tu?
So Mimi yang ni kan?
Yang tu.
Alright.
Okay. Yang animations ni just tekan satu lah.
Alright.
Okay. Bismillahirrahmanirrahim. I am Niswa. So I will present about syndrome that associated with congenital heart disease. There will be 4 syndrome that we'll discuss today. So the first one is, dengar tak? Semua dengar kan?
Dengar.
Okay. So the first one is Williams syndrome. So this is the features of a patient with Williams syndrome. So what is Williams syndrome? Is actually a rare disease which is an autosomal dominant. Usually how this Williams syndrome occurs is actually due to the small deletion of the chromosome during the gene process lah. And the chromosome that affected is the short arm 7, short arm 11.23. So what is the congenital heart disease that commonly associated with Williams syndrome is actually the supravalvular aortic valve stenosis, the most common one. And then they also can have pulmonary valve stenosis as well as peripheral pulmonary stenosis. So how this aortic stenosis happen in Williams syndrome? Just gambar just. Yes. So how this actually the aortic stenosis happen in Williams syndrome is actually due to the because of the small deletion of the chromosome just now. So this deletion is also cause mutation to the elastin gene. So what is the role of this elastin gene is actually for elasticity of the tissue. So in Williams syndrome, when there is a deletion of this chromosome, is actually a cause manifestation of the elastin arteriopathy. So this elastin arteriopathy causing the thickening of the arterial walls, then cause the narrowing of the lumen of the aorta and also its branches. So usually this elastin arteriopathy manifests characterized by the low level of the elastin, as well as the hyperproliferation of the smooth muscle cells at the aorta, and then this abnormal proliferation causing the narrowing of the common site is the proximal ascending aorta. However, it also can affect other parts such as the branches of the aorta, as well as pulmonary and coronary artery as well. So that's all for the congenital heart disease that associated with Williams syndrome. So other features that we can see in the Williams syndrome is actually the pathognomonic is the elfin facies of the patient, which is characterized by the craniofacial abnormalities, as well as we can look at the prominent forehead of the patient and the widely space of the eye, as well as the small mandible. And patient also can have dental hypoplasia. And one more thing about Williams syndrome, apart from the congenital heart disease, we also can diagnose patient if patient during the infant, when patient suddenly have hypercalcemia, high calcium level, usually idiopathic. We doesn't know what is the causes of the calcium, the rise in the calcium, so we can suspect patient to have Williams syndrome. That's all for the Williams syndrome.
Actually, Williams syndrome, usually, actually the main, a lot of these Williams children is actually detected not at birth lah, unless if they presented with calcium problem. So hypercalcemia, actually usually they are presented with cardiac problem lah. The main thing is actually murmur, and also they have murmur very early at birth. I think I've mentioned last class that murmur at birth is very rare, especially if it is due to structural heart disease kan. Because murmur from septal defect kan, ASD, VSD or PDA, they did not appear at birth. Okay, they appear later. Usually after macam PDA, usually after once the pulmonary pressure slightly reduced, then you can hear the murmur lah. Earliest will be around day 2, day 3 of life. That's the earliest lah. PDA quite earlier, maybe day 2, day 3, but VSD, ASD, sometimes after a week of life baru you can hear the murmur. But murmur because of stenosis, especially valve problem or vessel problem, such as pulmonary stenosis, like this one, supravalvular aortic stenosis kan. This can appear very early. Okay, because the turbulence occur very early lah. As soon as the blood circulating, then they start to have murmur lah. But actually the main problem with William is actually they are quite well actually at birth, except if they got problem with calcium. Hypercalcemia can cause, they rarely develop seizure, tapi biasa incidental lah. Hypercalcemia tu incidental, but not much can be done lah for the hypercalcemia. It will resolve as time goes. Okay.
Dia infantile je.
But this is quite common now. William is quite common. Because later on they will develop mental retardation semua tu lah. Okay, next.
Okay. So I would like to add, what is the symptom of hypercalcemia? If one of it is a loss of appetite, irritability, weakness, easy fatigability, as well as abdominal and muscle pain. So if patient look irritable, so we can suspect also patient have to have high calcium as well.
Because these are actually detected very early on during the period. So most of the time they are quite asymptomatic. Sometimes you just take blood and then noted, patient ni ada got heart problems. We know there's structural defect, and on top of that, because the facial features are not that prominent at birth. Tapi then noted, you can see hypercalcemia. Then that's when you detected. You suspect William. Okay.
Next, Jess. So the second syndrome is I will talk about is Turner syndrome. So what is the Turner syndrome? Is actually the absence of one set of gene from the short arm of one X chromosome, meaning that they only have one X. So SO lah, 45X. So what is the next, Jess? What is the most common heart defect that occur in Turner syndrome is coarctation of the aorta. the most common one. However, the patient also can have bicuspid aortic valve as well as post-stenotic aortic dilatation with aneurysm. However, this is usually occur later in life. So, how this actually the congenital heart or coarctation of the aorta occur in Turner syndrome? Some hypothesis has been postulated in several articles, whereby they mention that this origin of the congenital heart disease is related to the lymphatic hyperplasia or lymphatic obstruction in utero. Because if we can actually in Turner syndrome, usually we can suspect the baby or the infant to have Turner syndrome, whereby we can see during ultrasound antenatally, whereby there will be presence of the fetal edema at the neck, hands or feet, or there will also presence of the cystic hygroma. So this patient usually we can suspect them to have Turner syndrome. So how this coarctation of the aorta occur in Turner syndrome is actually due to the lymphatic obstruction, whereby this occur in utero, and then these dilated lymphatic vessels causing obstruction around the aortic root, and then cause the compression of the aorta, later cause aortic deformities. So this compression and also obstruction causing the low blood flows across the arch of the aorta as well as the isthmus that contribute to the aortic coarctation. That's all for the Turner syndrome and how this coarctation of the aorta occur in Turner syndrome. And some of the features that we can see in Turner syndrome, one of it is short stature. Usually the cardinal features of the Turner syndrome is the short statures. And sometimes this is the only abnormality that we can see in the children as well, the short stature. However, the patient also can have the neck webbing. You can see in the pictures, right? From the pictures, there is a neck webbing of the neck or the thick neck. And then the patient also can have other features such as delayed puberty, the infertility, hypothyroidism, and so on. A lot more lah.
Okay, good. Actually, Turner syndrome is not that uncommon. Okay, the most common among the four is actually Down syndrome. Second is Turner. Turner and DiGeorge is about the same. I think I see Turner more than DiGeorge lah. And then William. Last I've seen few William juga. So actually Turner, Turner is a chromosomal disorder kan. Oh, it's a monosomy. So it's a monosomy X. So Turner, the cardinal features at birth is actually the edema, peripheral edema. But it will resolve after a while. So you have to have high degree of suspicion lah. Because the rest are not that prominent. The other features are not that prominent. But in children, you can have Turner in your exam. Okay, Turner is easily available. They've got a lot of symptoms. They've got a lot of signs to be elicited in the exams, and they are quite well. So actually, the main prominent features of Turner definitely is the short stature. So they are eligible for growth hormone therapy. And on top of that is the delayed puberty. Okay, because most of them are sterile lah. They cannot. So most of them have problem with puberty. And then at birth, as you correctly mentioned, the coarc and coarc in Turner is usually very resistant to stenting. So usually you stand or you balloon, you did a balloon dilatation of the coarc. I mean minimally invasive procedure lah through angio kan. You did angio and then you did balloon what you call it, dilatation, but usually it will occur. Okay, it's not like the other non-syndromic coarc where usually you balloon it once and then it's settle lah. Tapi Turner biasa we balloon it twice and then if it's not it's not permanently repaired, then you have to surgically resect lah the coarc. Okay lah, next down. Any other questions? Tapi Turner you have to know in out, especially the clinical signs. They've got a lot of clinical signs.
Sorry, doctor, I would like to ask. For like Down syndrome, usually clinical, but for things like William, Turner, DiGeorge, do you have to do like fish?
Okay. Down syndrome and Turner is just conventional karyotyping. You can diagnose Down syndrome and Turner unless in some situation where it is actually the what do you call it, the not non-disjunction. Non-disjunction you can detect by conventional karyotyping. The what do you call it? There's 3 type kan karyotype chromosomal disorder. 3 causes. First, non-disjunction is the most common, and then you got the mosaicism. Mosaicism also you can detect by conventional karyotyping. The other one is the stable translocation. The stable translocation, sometimes karyotyping might miss. This is when you need fish lah. Then you have to do fish. Fish for Down and Turner. For disjorge, you have to do fish. You have to do fish study for disjorge lah. Casualty 2. William, actually conventional karyotyping can detect William, but most of the time we use fish lah for William. We've got a panel for all this for this syndrome, so it's easily diagnosed. It's just a cost of money. Tapi duit pun rasa dalam RM200 je the cost. So it's not expensive.
Sorry, Dr. Meaning, for only Down syndrome usually we diagnose clinically, but for the rest can we do clinical also or?
Turner we usually diagnose. Of course, Down syndrome also we diagnose by karyotyping. At birth we diagnose by clinical. There's no urgency to diagnose Down syndrome because it can easily diagnose by karyotyping. So do Turner. Turner is actually diagnosis by clinical most of the time because you don't need urgent. William also you don't need urgent. All this actually these 3, William, Down and Turner, they don't need an urgent genetic investigation. Most of the time they are diagnosed by clinical. After they discharge, then we arrange for karyotyping. Then after discharge, then usually we will confirm the diagnosis. But for DGeorge, it has to be confirmed early because some DGeorge baby with very severe anomaly, they may not survive long. Those with very complex heart structure, heart defect, these are the one that we need urgent fish probe untuk DGeorge, fish investigation to DGeorge. The rest doesn't need. Most of them are quite mild. They can be discharged live lah. Actually, William and Turner, most of them they discharge well. Down syndrome actually 50-50. If they admitted at birth, actually maybe about 20% will not discharge alive.
20% will not discharge alive.
Because a lot of complication. Down syndrome, they've got a lot of complication. Rather than William and Turner, most of them are quite okay. DGeorge depending. DGeorge, it depends on the severity of the heart problem now. But usually the heart problem cause difficulty like in managing DGeorge. But other problem usually okay lah. Okay, next. Okay, ada soalan?
I don't have any more question. The next presenter, she will
Down
open.
syndrome tak boleh. Down syndrome and DGeorge ni.
Down syndrome and DGeorge, the presenter macam
orang lain.
Okay.
Okay, orang lain.
Dia online. Dia different person. So later we'll go back to the Down syndrome and DGeorge. Doctor, is it okay, Doctor?
Okay.
Okay. Alright. Yeah, so here. Okay, alright. So here.
Yes.
Assalamualaikum warahmatullahi wabarakatuh. Can you hear me? Hello?
Yes.
So I'll be presenting about oxygen hemoglobin deposition curve. So firstly, this curve is very important because it describes how the blood carries oxygen inside our body. So the first thing I want you to look at this curve is the shape of the curve. So the shape of the curve is actually S in shape, sigmoid shape. So this is because of the property of hemoglobin, in which when it binds to one oxygen molecule, will become easier for the next unit, for the next molecules of oxygen to bind. So we know that in any hemoglobin molecule, we have 4 subunits. So this depends on the type of hemoglobin, HbA, HbA2, or HbF. So for example, in HbF, we have alpha subunit, 2 alpha subunits, as well as 2 gamma subunits. So if let's say one of the subunits bind to one oxygen molecule, this is it will become easier for the next molecule, oxygen molecule to bind. For example, first, because if oxygen molecule, hemoglobin molecule doesn't bind to anything, we call this as a tense configuration. So during this, when this configuration occurs, it's very difficult for any oxygen molecule to start to bind. But when the oxygen, when we increase the PO2, so the oxygen will be easier for to bind to the hemoglobin. So this is why the curve is sigmoid in shape. And then the next thing that I want you to see is that the curve is kind of plateau, kind of flat at very high PO2. So this means when the hemoglobin is saturated with oxygen, it will become very difficult for more oxygen molecules to bind. The only way we can increase this is by things like blood transfusion and so on. So in this curve, so I want you to focus on one curve. For example, the blue curve is the normal one. So at the higher PO2, this is where usually this is, represents lungs, where we have a very high PO2. So at very high PO2, we have a very saturated hemoglobin. So as we go down, go to the left at a low PO2, we see that the curve becomes steep, right? So this represents the tissue unloading. So if you take a look at the y-axis, the lower level of y-axis, that represents the unloading of hemoglobin, unloading of oxygen, sorry. So there are few factors that sometimes the body will shift the curve to the right or to the left, and this depends on a few factors. So if the body shifts the curve to the right, then if take any given PO2, let's say at 50, you can see that at y-axis it equals to 80 something, 81 or 82 oxygen saturation. But if we shift the curve to the right, then the y-axis will become lower. So at 50 PO2, you can see that it reduces to 70 something. So this means there will be more oxygen unloading from the lung. So among the factors that increase the oxygen unloading, in other words, shift the curve to the right, we can remember this by a mnemonic called cadet face right. So C for CO2, A for acidity or increase in H plus, or increase in H plus or reduction in pH value. D for 2,3-DPG, which is a byproduct of glycolysis. E for exercise and T for temperature. Anything that increase this value will shift the curve to the right. In other words, it will cause more unloading of oxygen. And if the body shift the curve to the left, that means the green one, the green curve, that means the hemoglobin, the oxygen has higher hemoglobin, higher affinity with hemoglobin, so there will be less unloading. So this occurs in certain situations. It's actually the vice versa of aforementioned factors, but also includes things like HbF, because in HbF you want to have higher affinity for oxygen molecules so that you can take oxygen molecules from maternal circulation. I guess That's all for my presentation.
Okay, good, good. Any question? Any question, guys? Understand kan?
Sorry nak tanya, usually yang HBF tu they will lose from the newborn bila macam when is it depleted?
Usually around 6 months of 6 months of age. You know that AGF is produced within the first 6 months. So if the patient has like 2 years teaching, patient has beta thalassemia or so on, then they will start producing symptoms from 6 months onwards because they cannot produce HbA, the adult form of hemoglobin.
Okay. Thank you, sir. Thank you, sir, Harun.
Okay, good, good. Okay, so let me just briefly summarize now. So we are concerned about the affinity kan. When you look at the oxygen hemoglobin dissociation curve, we are concerned about the loading unloading of oxygen, or what we call it affinity of the oxygen. Okay, when you say shifted to the left, means the graph become the blue graph become the green one at the top. Okay, shifted to the left means more affinity to oxygen, so less likely to release oxygen from the hemoglobin. Okay, faham? Increased affinity means at high temperature, at low temperature, in infant with low DPG or infant with high pH kan, alkalosis, the oxygen tend to bind stronger to the hemoglobin, so less it's more difficult to release the oxygen to the tissue. Okay, therefore, even at high oxygen, okay, even at high concentration of oxygen, therefore at lower concentration of oxygen, the SpO2 will be high. So if you look at the baby, because they've got fetal hemoglobin compared to adult, fetal hemoglobin has higher affinity to oxygen. Therefore, if you look at a baby with SpO2 of 90%, okay, you look at a baby with SpO2 of 90%, okay, look at here lah, look at the graph, okay, the PO2 is actually only about 50 millimeter mercury. Okay, understand kan? But if you take ABG of an adult with 90% saturation of oxygen saturation, the PaO2 will be around 60, 70. Faham tak? Okay, because baby they need less oxygen, okay, to concentrate their hemoglobin, to increase the hemoglobin SpO2 concentration, to increase their SpO2. Okay, so what does this mean? Okay, this means that if a baby is cyanosed, okay, if a baby is cyanosed, means the SpO2 is 80, for example, compared to adult, they have lesser oxygen. Okay, faham tak? They have lesser oxygen. With the same degree of cyanosis, they've got lesser oxygen in their blood, because the PO2 will be lower is lower than in adult. However, so it seems like, oh, baby lagi bahaya lah if they're cyanosed. The same degree of cyanosis is more dangerous in baby. However, because baby got fetal hemoglobin, so the effect is equal. Okay, faham kan? So that's why Allah bagi dia fetal hemoglobin. Therefore, even though they have less oxygen in the blood, but they can still okay. Okay, macam tu lah. Okay, and the other thing is, so we've mentioned earlier, definition of cyanosis is when. Okay, what is the definition of cyanosis? Itu siapa yang present, yang lady kan, salah seorang present itu kan. So what is the definition of cyanosis?
Cyanosis presented when there is more than 3 grams per deciliter of hemoglobin in the oxygenated blood. Okay.
Okay. So cyanosis is apparent. I mean, you can see cyanosis if more than 4 grams per deciliter of blood is not oxygenized. Faham tak? So kalau dia ada 15 hemoglobin you, 15 gram per deciliter, if you got 4 deoxygenated hemoglobin, 4 gram deoxygenated hemoglobin in your blood, you will become sinus. You will look sinus. Okay. Okay. However, okay. So macam mana kalau kita ada lower hemoglobin? Contoh kalau I ada 10 hemoglobin. Okay. Okay. For example, okay. Let's see this. Okay. Look at the curve, the blue curve. Okay. If you got 2 adult, okay, two person, with a blood PO2 of 100, contoh blood PO2 of 70, okay. So you've got 2 person with blood PO2 of 70, okay, of 70 lah, of 70s now. 70 tak biasa. Okay, 60 lah senang, 60. Okay, if you got an adult with 2 adult with PO2 of 60, okay, what is the SPO2? It's usually around 90 lah kan, 90, 89, 90 macam tu. So you've got 2 adults, similar adults, with PO2 of 60, okay, the saturation will be around 89 to 90. Tak, ambil yang warna biru ni, the thick blue graph. So PO2 of 60, you get the SPO2 of around 90 kan. Okay, tapi if the person A, the hemoglobin is 15 for example, okay, so chances are more of this hemoglobin, because there's only 60 millimeter mercury of oxygen, so more hemoglobin will be deoxygenized. So this person with hemoglobin of 15 gram per deciliter, he will look sinus, even though the PO2 is 60, but he will look sinus because there's a lot of hemoglobin to be concentrated, so more hemoglobin will be deoxygenized, will be less concentrated. Okay, faham kan? Tapi if another one got HB of 10, chances are the saturation will be 100, because with 60 you can actually saturate almost all of the hemoglobin if you got only 10 hemoglobin. Faham tak? So the degree of anemia, the amount of hemoglobin in the blood will actually affect your appearance, your cyanotic appearance. Okay, faham kan? Okay, that's why in baby, okay, baby they are born with a lot of hemoglobin lah. Most of them got normal hemoglobin in baby is around 14 to 20 kan. So they've got a lot of hemoglobin. That's why when with a little drop, even with small amount of drop in PaO2, they can look sinus. But in adult, even with the same degree of drop in PaO2, we may not look sinus in adult or in older children. That's why when you are doing examination, clinical examination, sometimes the child doesn't look sinus, okay, from outside because HB might be low lah. So those children with cyanotic heart disease with low hemoglobin, they will not look sinus unless if you look carefully at the mucosa lah, then you can detect the cyanosis. Tapi in exam, kalau you just look at the child from outside, you did not carefully look at the mucosa, especially the tongue, then you will miss the cyanosis. Okay, faham? Because with the SpO2 of 90, they won't become sinus unless if they got polycythemia. Okay, faham kan? Okay, that's a clinical significance lah of the hemoglobin dissociation curve. Okay, any question?
Doctor, I have a question. So, for example, for patient who has congenital, who have cyanotic congenital heart disease, they usually have polycythemia, right, doctor? So they are more likely to be cyanosis, but they are not hypoxic. Is it like that?
No, because their PaO2 will never more than 100. They will never reach PaO2 more than 100, even though if you give 100% oxygen, because there will always a mixture of blood. Okay, tapi you correctly mentioned a lot of, usually, in ideal situation, children with cyanotic heart disease, they will become polycythemic because the body will compensate lah, because there's not enough oxygen in the blood, kan, in the artery, there's not enough oxygen. So what they did is they will increase the amount of hemoglobin to increase the oxygen carrying capacity. Faham kan? They increase the oxygen carrying capacity in the body lah, because they need more. So the more active the child, the growing child, they should have higher hemoglobin. Usually we aim for those with cyanotic heart disease, we aim the hematocrit should be more than 40. Less than 40 is considered anemia lah. In those with usually 40 tu dalam 14 to 15 lah hemoglobin. HB level. Macam kalau budak biasa kan, even budak biasa we won't transfuse unless if HB less than 8. Like in normal children, or if patient symptomatic. Tapi in cyanotic heart, we always aim HB hematocrit of 40. Less than that, we have to transfuse. However, because IDA is very common in this country, so a lot of them affected with IDA, so they've got low hemoglobin. So you won't be surprised that in your exam, a child with diagnosis of cyanotic heart disease, but they don't look sinus, but they do have clubbing. Okay, they do have clubbing, but they don't look sinus, because a lot of the children in our setting, they've got IDA lah on top. Okay, faham tak? Memang kalau dalam buku kalau you baca, when you examine child with cyanotic heart, one of the thing you have to look at the conjunctiva kan. Conjunctiva, dia ada suffusion lah. Suffusion is what you call it? Plethoric lah, plethoric conjunctiva. Okay, but that's not the case lah most of the time, especially dekat our area tak sure Kuantan, tapi kalau Kelantan tu memang a lot of IDA lah. Okay, any other questions?
Sorry, Doctor, I would like to ask a question, but this one is in regards to the previous slide. So, usually kalau patient with hypercalcemia in adults, they can present with bone, moan, groan, and stone. But for pediatric, do they have any similar features or?
Later. In neonates, they won't have features. For example, like William kan, William usually the hypercalcemia will resolve as times goes. So by the time of they reach childhood kan, macam dah 5-6 tahun, usually they won't have that problem with hypercalcemia. It's a transient. Tapi in neonates, most of the time they don't have symptoms. They don't have symptoms.
Even like no changes in the feeding pun tak ada.
Sometimes lah, kalau yang very severe tu, you ada nampak irritability sikit, feeding intolerance, but it's a very non-specific symptoms lah.
Okay, thank you, Doctor.
Okay, come.
Doctor, I would like to add, usually the calcium will be normalized around age of 12 months. Kalau in baby.
Age of 12 months. Good. Okay, next. Very good.
Okay, because the next presenter will be presenting her own slide, so I'll stop my share now.
Okay.
Anissa, I'll pass the floor to you.
Okay. Can you see my slide? Okay. So today I'll be presenting about anatomy of the great vessel of the heart. As we all know that there are 5 great vessels of the heart, which are that leave and enter the both sides of the heart. For the right side, there are IVC, inferior vena cava, superior vena cava, and the pulmonary artery. While for the right side, there are the pulmonary vein and also the aorta. So basically, the right side bring the deox into blood, and the left side bring the ox into blood. So and in human circulation, there are 2 different separate systems, which are the pulmonary system, pulmonary circulation, and the systemic circulation. So for the systemic circulation, it consisted of the aorta that bring out the ox into blood through the systemic circulation, and that the one that bring into the heart bag is the IVC and the SVC. While for the pulmonary circulation, which are the pulmonary vessel, the vein and the artery. Okay, so we go first to the IVC, which is the largest vein in the heart, and the IVC starting from the convergence at the lowest point, from the convergence of the iliac vein, and then as it goes through along to the right atrium, it receives several drainage from the vein, which are the renal vein, the suprarenal vein, the lumbar, and also the hepatic vein. And as it enters into the SVC opening of the right atrium, which is at the inferior, it is correspond to the fifth intercostal cartilage. Okay, and you know that the IVC drains all the blood from the lower extremity, and for the SVC, which is also the same, brings the deoxygenated blood, which from the upper extremity and the head. It also receives several drainage from the vein, which are the internal jugular, and then the subclavian, as well as the thyroid vein. And it also received the bypass vein, which from the IVC, the azygous vein. And the most important part of the SVC is that it also received the lymphatic drainage from the thoracic lymphatic duct. And then as it entered to the superior part of the right atrium, into the right atrium. And then all the blood will be pushed out into the right ventricle, and then into the pulmonary valve, into the and as it goes through the pulmonary valve, it will run to the pulmonary artery. And just right after it enter the pulmonary artery, there is dilated area. You can see here. Can you see my precursor? The dilated area here called the pulmonary sinus, where this area is to prevent the cups from the cusp of the valve from sticking to the pulmonary artery. And then the deoxygenated blood will be bring out to the lung by the pulmonary artery for the gas exchange. And then after the gas exchange happen, the oxygenated blood will be bring back to the heart, to the left atrium, through the four opening of the pulmonary vein, which the two superior, two inferior, or two right and two left. And the pulmonary valve is also called as a valveless valve because it doesn't need to go against the gravity. And the last part of the great vessel is the aorta, this one. Okay, so the aorta having subdivision of the ascending, the aortic arch, and the descending. And the descending part is further divided into the thoracic part and also the abdominal aorta. So let's go to the first part, which is the ascending part. After the blood was brought from the left atrium into the left ventricle and goes into the aortic valve, same as the vein, same as the pulmonary artery, it also have a dilated area called the aortic sinus. This aortic sinus will branch into two branches of the coronary artery, the right and left. That was the first branch, and then the second branch is at the aortic arch, which it gives off three branches, major branches: the brachiocephalic trunk, which further divide into the right subclavian and also right common carotid. And then the second branch is the left common carotid artery, and the last is the left subclavian artery. So for the aortic arch, there also other part which is important, which is the carotid body that play part for the baroreceptor and also the chemoreceptor, the chemical sensory. So this baroreceptor will detect any changes in the pH, while the chemoreceptor will detect any changes in the blood pH, oxygen, and also and also carbon dioxide level. And all these changes in the parameter will be sent impulse into the medulla oblongata before being translated by the brain and send feedback to the autonomic nervous system. And then for the descending part, which first is the thoracic aorta, it gives branch of the bronchial branches, mediastinal branches, esophageal, and as well as the phrenic branches. And the last part is of the descending aorta is the abdominal aorta, which just started below the diaphragm, and it gives branch of the, it's not stated here, but suprarenal and renal artery. And the descending aorta end by the bifurcation of the right and left iliac artery. So I think that's all for the anatomy of the great vessels.
Okay, so let's briefly go. Let's briefly identify. Leave your presentation on. So let's briefly go to one by one and look at the site of pathology lah. So let's go to the first aorta kan, aorta. So where is PDA usually?
PDA is just after the PDA from the pulmonary artery to the arch of aorta.
Okay, so it's actually branched out from the arch of aorta. Most of the time it appears between left common carotid and also left subclavian artery, around that area. But sometimes it can be, but around there lah, it can be in between the brachiocephalic and also common carotid, or it can be between common carotid, left common carotid and left subclavian, or it can be after the subclavian. But usually it has, most of the time it's actually at the arc. Okay, so what this implies, okay, the arc is actually supplying the upper limb and also the head. Okay, kan? Because it supplies the head, okay, it supplies the head, the brain. Therefore, Allah make it wonderful that you don't have mixing. Actually, most of the cyanotic heart, they don't get mixing at this area. They don't get mixing unless if the defect is actually at the right side, ataupun defect dia actually usually at the right side lah. Those defect at the right side, they have mixing very early. But other cyanotic heart, they don't have mixing at the arc level, at the aortic arc level. They've got the mixing after the post PDA. Okay, faham kan? Because the mixing is post PDA, because at the PDA level in cyanotic heart, a lot of time when especially those that are ductal dependent, so they've got right side blood from the right side, from the right side, the deoxygenated blood from the right side will actually it's a right to left shunt. So it's from deoxygenated blood from the right side will shunt to the left side and mix post ductally. Faham tak? Okay, will mix postductally. So that's why one of the best, one of the method to diagnose ductal dependent cyanotic heart disease or ductal dependent cyanotic heart disease is by comparing the SpO2 of the upper limbs and lower limb. Okay, if there's a discrepancies between the upper limb and lower limb SpO2, it means there is a mixing postductally. Faham tak? So there's only two conditions that can cause mixing postductally. There are a few other very rare condition now, but in general there's only two conditions that cause postductal mixing. Or actually there's three conditions. Postductal mixing or reduced SpO2 in the lower limb. There's only three conditions. Okay, one is cyanotic heart disease, ductal dependent cyanotic heart disease. Okay, if a baby, you look at the SpO2 at the upper limb and lower limb, there's a discrepancy of more than 3, then chances are this child has a ductal dependent cyanotic heart disease. Okay, that's number one. Or there's a shunting, right to left shunt at the PDA level. Okay, to number one. The second, which is more common, is actually lung pathology, the PPHN, persistent pulmonary hypertension of newborn. Because the pressure in the pulmonary is very high, so it's shunt back. So there's a reverse flow of blood from the right side to the left side. So it's a right to left shunt through the PDA. So there will be mixing postductally. So this is when you will find the discrepancies between the upper limb and lower limb SpO2. And the third one is coarctation of the aorta, especially the severe coarctation. Critical coarct or severe coarctation, you will get discrepancies between SpO2 upper limb and lower limb. That's why one of the earliest investigation that you have to do when you approach a child with cyanosis is by palpating the bilateral femoral pulse. That's number one. I'm talking about infant lah, in neonates, because most of these conditions diagnosed in neonates. So first, make sure in any cardiac cases examination, you have to check the bilateral femoral pulse. Okay, and ideally we would like to compare with the upper limb. Okay, but in neonates it's very difficult because the heart rate is very high. So at least you palpate the both femoral. If the femoral is weak, chances are this child have stenosis, coarctation of the aorta or critical coarct. Okay, Tu number one lah. And then the other one is you have to offer, you have to say, I would like to assess the SpO2, I would like to compare the SpO2 between upper limb and lower limb. Okay, that's number one. And that's number two. And then you have to say, I want to compare the BP upper limb and lower limb. Okay, faham kan? Okay, that's pathology around there lah, at the co-op. Usually the PDA is there, so you can get acyanotic, which is the PDA itself, and cyanotic when you get left to right shunt at the ductal level. Okay, and then the pulmonary vein, the main pathology at pulmonary vein is the TAPVD. Okay, TAPVD is a total anomaly of pulmonary vein drainage, atau TAPVR. So what happened is, we've got 4 pulmonary vein. Okay, remember, a lot of us, at least about 10-20 of us, we've got anomaly at the pulmonary vein, but this will be undetected unless you do echo. Then you'll notice lah. Because what happens, sometimes some people, they only got 2 pulmonary vein that enter the left ventricle. The other 2 will enter somewhere else. Most of the time it will enter the right atrium. Okay, faham tak? Some of us, when we did echo, maybe 2 or 3 of our pulmonary vein enter the left atrium. The other one maybe enter the right atrium, or the other one maybe enter back to inferior vena cava, superior vena cava. Okay, this is what we call partial venous anomalous venous return. This is partial anomalous venous return. They are most of them asymptomatic. Okay. However, sometimes they can get heart failure lah, depending on where the pulmonary vein inserted. Okay. In TAPVD, all the 4 did not enter the left atrium. Instead, it enter either supracardiac, which is enter the pulmonary artery or superior vena cava, or cardiac TAPVD, which means it's enter straight to the right atrium, straight to the right ventricle, or occasionally to the left ventricle. Or infracardiac, which is the worst, is enter the inferior vena cava. Okay, faham tak? So that's why they become sinus. Because if it's enter anything it's enter at the right side. Anything at the right side, which is the superior vena cava or inferior vena cava, or right side, right atrium or right ventricle, then they will get a parallel circulation. So the right side will circle at the right side. The left side will circle, the circulation of the systemic circulation will just circulate around there, and the pulmonary circulation will circulate around there. So they will need a mixing, conduit lah, which is a PDA or ASD to survive. Similar to TGA, they will become similar to TGA. So TAPVD are very similar to TGA in terms of the pathology. There will be we call it a collateral, a parallel circulation. Okay, without mixing. So they will very ductal dependent lah. They will be ductal dependent, or they will require ASD lah for mixing. Okay lah, the rest essential tak important sangat. The rest you ada pulmonary stenosis, yang tu semua not important lah. Okay, faham tak? Ideally I have to draw lah, tapi macam I tak tahu macam nak draw dekat guna Zoom ni. Okay, ada soalan?
Doctor, I would like to ask about TAPVR. Inessa said that there is when macam clinical manifestation tu dia ada divide into infant with obstruction or infant without obstruction. So obstruction is usually occur at where, doctor? Pulmonary vein ke?
Obstruction dekat pulmonary vein, yes. Dia macam ni. Obstruction means sekejap I'm not sure lah sekejap. Kalau obstruction, sekejap. Dia depends on the entry. Here is it. Okay, here. Okay. There's a 4 types kan, supracardiac, cardiac, infracardiac dan mixed type. Okay, obstruction occur kalau dekat insertion tu, I mean insertion of pulmonary vein to the heart kan, to the heart or to the vessel. If there's obstruction, for example, if they enter near the valve ataupun enter at the high pressure punya area macam biasanya yang ada obstruction is the cardiac type dengan the cardiac type lah usually yang ada obstruction ni. So what happen, because when they've got obstruction of the flow of the blood kan, so the blood will actually accumulate in the lung, because the pulmonary vein is actually drain the blood from lung to the heart. If there's obstruction at the insertion of the pulmonary vein into the heart ataupun into the vessel, so the blood will actually accumulate in the lung. Okay, so they reduce flow kan, so bila reduce flow, so there will be congestion of the lung, so they get failure. So the only things that differentiate between obstructed TAPVD or non-obstructed is actually the failure symptoms. If TAPVD with failure symptoms, then we know there's some obstruction. At which level, then you kena buat echo lah. Most of them is at the insertion site lah. Insertion site of the pulmonary vein. Okay kan?
Okay, thank you, Doktor.
Okay. Okay, boleh move to the next lah. Tinggal satu je kan? Kedua ni. Ini long case pula.
Okay, boleh pass ke floor tu awal muncul
Doctor, for the meantime, I have one question.
Aha.
For example, in PPHN or any kind of lesion which cause right to left shunt, will the shunting occurs at level of foramen ovale?
Yes.
It also occurs there.
If there's foramen ovale, I mean, if there is pattern foramen ovale, then there will be shunting lah. In general, ductal dependent lesion or cyanotic heart, they will need either ASD or PDA. VSD is not very helpful lah. VSD because VSD is actually at the left side, so it is not useful for cyanotic heart. So cyanotic heart, you need to have ASD. The mixing has to be occur before the lung level. PDA, it can be both. In PDA, you can have mixing post-lung or pre-lung mixing, post-pulmonary or pre-pulmonary mixing. For example, in PDA, in VSD kan, there will be mixing at PDA level. We don't call it mixing lah. There will be shunt at the PDA level, but it will be left to right shunt. That's why they get pulmonary. That's why they get breathless. They get failure symptoms, because now there's a left to right shunt, so there's a lot of high pressure blood from the left side to the pulmonary in VSD, in PDA. Okay, faham tak? So the lung become congested, they become failure. Okay. But in cyanotic heart, especially ductal dependent, they are also shunt, but it's from the right to the left, from the pulmonary to the heart. Pulmonary has higher pressure than the heart because of obstruction, most of them because of obstruction at the left side. So they've got high pressure in the pulmonary, so they've got right to left shunt. So but PDA, they can act as both. Tapi ASD, they will always have right to left shunt. They won't have shunt tau in ASD. That's why even in ASD, you won't listen the murmur at the ASD level. The murmur is actually at the pulmonary valve. Okay, murmur of ASD is actually at the pulmonary valve. So clinically, They are very similar to pulmonary stenosis because they've got a relative pulmonary stenosis. Faham kan? Okay, this I think better you in detail you kena tanya Dr. Taufik apa atau kena lukis.
But doctor, for example, in the case of PPHN earlier, you mentioned that the mixing will occur postductal, right? Will the mixing also occur preductal because of the high pressure in the pulmonary circulation? So blood from the right atrium to they shine through the foramen ovale to the left? No.
No, it won't because left ventricle ni very high pressure tau. Left ventricle will be very high pressure. They can have lah. They can have if the pulmonary pressure is very high. They can have that. This is when you look at the SpO2 of the upper limb, they will become sinus as well. They will become sinus. Okay, if very high pressure, then will become PPHN. PPHN by definition is that lah, which means the mixing. I mean right to left shunt, actually causing left ventricle. I mean to pump against high pressure lah. So they can get mixing pre or postductally, but definitely the postductally will be worse. Okay, but at that time usually kalau you tak treat PPHN, once you dah ada mixing at the ventricle level kan, then definitely patient ni akan die lah, unless you do something. It's very difficult to manage PPHN. Tapi itulah. Tapi dia akan ada mixing cut ni.
So doktor, maksudnya if we do the SpO2 level compare upper limb dengan lower limb, the upper limb will also not be normal lah doktor?
No, not be normal, tapi the lower limb will be lower.
Okay. Thank you doktor.
Okay, Anis, boleh datang.
Boleh dengar kan?
Ya, dengar dah.
So, sorry for the delay. So, continue with the Down syndrome. So, basically, Down syndrome or the other names is trisomy 21. So, what does it mean by trisomy? Because there is extra chromosomes at the position 21. So, because of this extra chromosomes, hypothesis can be done so that due to the extra chromosomes, so there will be overexpression of the genes at the chromosome 21. Therefore, it leads to the phenotypic abnormality that we can see in Down syndrome. So, so in Down syndrome, as you can see in the slide, the features of Down syndrome, there can be a decreased muscle tone at birth. So, shown with Down syndrome, usually there can be hypotonia. And for the abnormalities of the face, they can have a round face, especially the round face and ethnicity. And at the back side of the head, there will be a flat occiput. And at the eye, you can see that there will be upward slanting of the eyes, which means that the temporal feature is higher than the nasal feature. And then there will be also epicanthid hole, and the ears are small, low set ears and small ears, and also the mouth is small and also protruding tongue. And that is for the face. And there will be also limb anomalies. For example, as you can see, there will be a single palmar crease, and also at the foot there will be we call it as a white sandal gap, or there is an life gap between the toes and also the second finger. And other than these characteristic bases and also the limb anomalies, they can also have mental retardation or intellectual disability and also cardiac congenital heart disease. So for the congenital heart disease, the most common is ADSD, the atrioventricular sector defect, or other names is endocardial Cushing defect. So as you can see in the right, that is ADSD, and the commonness is the complete type, which means there will be a connection between the atrium and also the ventricle, and also there will be a deformity of the ventricular valve. So the next congenital heart disease is ventricular sector defect. isolated BST, and then isolated ASD. Other than that, there will be they also can have patent ductus arteriosus, and the less common is the cardiopelvis. Okay, so that is for Down syndrome. Ada any question tak? Question doktor nak add apa-apa ke pasal Down syndrome? Okay. So for Diger syndrome, so basically Diger syndrome ni is due to the microdeletion of the long arm of a part of long arm of the chromosome 22. So the features of Diger syndrome you can look from the mnemonic /22. So C is for congenital heart disease, A for abnormotasis, T is tiny hypoplasia, and C is class pilot, and the last one is hypocalcemia. So what happened in Diger syndrome is that because of the microdeletion of the chromosome 22, so it will affect the embryological process. So in Diger syndrome, the portion of the heart, head, neck, and thymus, and also parathyroid is from the third and the fourth, from the third and the fourth pharyngeal pulse. So because of this microdeletion, so it will affect the descent of this pulse into the designated place. So there will be a defect that leads to the pneumonic ventricular fashion. So for the congenital heart disease, first the first is actually the most common is conotruncal anomaly, which I will present later. So there will be pathology of palate, truncus arteriosus, acute defect, and also BST, and also conotruncal anomaly, between the abnormalities of the blood vessels of the heart. So in Nancy, you mentioned that most common is interrupted IRTH, which Aklan had already mentioned previously. So the most common is interrupted IRTH type B, which means the IRTH it was interrupted at the between the left artery and left subclavian artery. So and then the ductus arteriosus they enlarged and first descending aorta. So that is interrupted IRTH type B. And it also can be associated with right-sided IRTI. So as you can see in the picture, normally with the IRTH will be at the left side in front of the trachea, but for right IRTH, the IRTH will be behind the trachea. So that's all for the test and also Down syndrome.
Okay, good. I want to add only one thing about Down syndrome. Okay, which is you have to know in out about Down syndrome. Okay, from the genetic until the complication and management, because this is a need to know topic lah for all doctors, especially pediatric. Okay, and in Down syndrome, the problem with Down syndrome is in terms of clinical assessment, it will be very difficult because you're not sure whether the breathlessness, because they are almost always breathless because they get very poor tone, they've got very weak muscle tone. They look always breathless. So you're not sure whether the breathless because of the poor failure control or because of the tone. And on top of that, because general concept is Down syndrome, they always have high pulmonary pressure compared to normal baby lah. They've got high pulmonary pressure. So theoretically, they should have less failure symptoms. The failure symptoms should be better lah compared to normal baby. But assessment of failure and heart problem in Down syndrome will be very difficult because they've got concomitant heart and also lung problem. And on top of that, other problems such as they always have poor sucking, which is a sign of failure, failure symptoms. But sometimes they are not actually that bad. Okay, clinically they may look bad, but actually they are not. Okay, I think you have to know lah about Down syndrome. About D George, okay, D George is actually a spectrum lah. It is a spectrum of syndrome. It's not a disease. It's not a syndrome. D George syndrome. D George syndrome is only one spectrum of the 22q11 deletion. Okay, because they can present in spectrum. They can present very bad, or they can present not that bad. Okay, in general, the principle is in D George is they've got midline defect. Okay, they've got midline defect from top to the bottom. Okay, occasionally they've got brain problem, but they've got midline defect, especially at the thoracic area. So what midline structure you've got? You've got your thymus. So they don't have thymus. So what happens if you don't have thymus? You are prone to infection, kan? You've got primary immunodeficiency lah. You've got immunodeficiency. Okay. And then on top of that, you've got problem with your thyroid gland, kan? Parathyroid gland, especially the parathyroid gland. Thyroid gland is not that affected lah, tapi parathyroid affected. So what is the role of parathyroid is for calcium punya homeostasis, kan? So they've got hypocalcemia. So a lot of time, D George problem in D George baby rise from the cardiac problem, but they also got problem with seizure. Okay, a lot of them got very poor control seizure, and actually most of them, the initial presentation is fitted at birth, fitted at early onset fitting lah, and that's when we suspect D George. Okay, and then because of it midline, the main problem is midline. So most of the defect is actually affecting the blood vessel. So the most common is truncus arteriosus, TOF. They've got double outlet right ventricle. They've got all sort of ni lah, aorta and pulmonary artery punya problem. Occasionally they've got septal defect juga lah, BST, ASD semua. Okay lah, tu je lah kot about D George. And they will almost always have cleft palate and cleft lip, especially cleft palate. Okay. Okay, tu kot. Boleh move tu lah, next slide. Lepas tu kita boleh lihat. Okay kan, ada soalan lagi?
Doctor, I'd like to ask for like in kalau case Down syndrome, kalau on amnio there's on amniocentesis dapat tahu the baby is Down syndrome. So dia terus buat detail scan ke, or they see whether patient ada symptoms afterward baru dia assess for cardiac abnormality?
Usually kan amniocentesis kita buat after detail scan kan?
After detail scan. Oh.
I thought that's how it works kan? You do detail scan at week 10 to 12 macam tu lah usually. Detail scan looks anomaly, then you detect anomaly, then you do CVS ataupun amniocentesis lah. You do CVS first ke amniocentesis first? Amniocentesis first kot, then you buat CVS. Later baru you buat CVS. So usually macam tu lah. But in Malaysia setting kan, because TOP is not allowed in Malaysia kan, except for few condition lah. Down syndrome, you are not allowed to do TOP in Malaysia for Down syndrome. So if you diagnose Down syndrome antenatally, you are not allowed to do TOP because the prognosis is good. Tapi if you found Edward ke ataupun hydrops, memang severe hydrops, even hemophilia pun, if you detect hemophilia antenatally, you can abort. Thalassemia pun sama. So if parents are thalassemia carrier and then they detect baby is a major, then echo-major patwa you are allowed to terminate untuk thalassemia major and also hemophilia. Tapi untuk Down syndrome tak boleh. Okay.
Okay. Thank you, Doctor.
Okay.
If I'm not mistaken, Anis Wadati is the last presenter. So far, all of the group have already presented, Doctor.
Okay, actually one more yang I prepared lah for you guys. Management of that spell kan. I think one of your objectives is to learn about management of that spell. Okay, but anyone can tell me what is hypercentric spell? Anyone? Hypercentric spell?
Also known as TED spell. It occurs as an acute exacerbation of a stable TOF. So only occur during exertion. Patient is crying, laughing, or doing any strenuous activity. Only then there will be the development of the cyanosis.
What?
Sorry, Doctor?
What causes cyanosis in that
Oh,
spell?
because in those exertional state, there will be increase in the systemic resistance. So there will be more. There will be more shunting from the right to left because of the. Tak ingat causes dia apa. Tapi there were more right to left shunt. Sorry, Doctor.
Ya ke more right to left shunt?
Is it because of the increase in peripheral resistance, which causes reduce in venous return, and because of that, which happens in, for example, when patient do basal maneuver, such as in crying and during feeding, so there's like increase in peripheral resistance. Due to the increase in peripheral resistance, there is reduce in venous return, and due to the reduce in venous return, it will exacerbate the hypercyanotic. It will cause the hypercyanotic spell. That's from my understanding, but I'm not so sure, Doctor.
So you are partially correct. Okay, you are partially correct. But in general, hypercentric spell. Okay, I did mention about pathophysiology of cyanosis in congenital disease kan. You've got mixing. Okay, you've got mixing. You've got reduced flow to the pulmonary, ataupun reduced flow to you got right outflow obstruction, ataupun you got left outflow obstruction. So these are the three main mixing. Okay, mixing either at right side atau left side, doesn't matter, mixing right to left shunt. And then second, right outflow obstruction, okay, leading to reduced oxygenation of blood dekat pulmonary level, ataupun you ada left upstream obstruction. Outflow obstruction, for example, macam macam critical co-arc ataupun interrupted arc kan. So in TOF, the main problem is actually the right outflow obstruction. Okay, co-arc ni, the main problem with TOF is actually the pulmonary stenosis. Okay, what happened in baby? Okay, in baby, during the development of the fetus, kan, they've got pulmonary stenosis. So what happened? Because if they've got pulmonary stenosis, so they will compensate by their moving the arc. So they nama term ni? Apa nama term ni? I haven't lupa dah.
Position of aorta. Overriding.
Overriding, yes. So they override the aorta to the right side. Okay, faham tak? Okay, to the right side, and then they create the VSD. So VSD cannot close because now they need more blood, so they cannot close the VSD. So what happened? They have to override the aorta, and then they will keep the VSD open to make sure there's a lot of blood will go through the aorta. Because if they didn't do that, if the baby, if Allah keep it there, keep the pulmonary stenosis uncompensated, then the baby will die. Okay, so TOF is actually a compensatory development lah. The compensatory mechanism occurred in baby structurally because of pulmonary stenosis. So the main problem in TOF is actually the pulmonary stenosis. That's why in baby with very severe pulmonary stenosis, they are ductal dependent. They need PDA. In baby with mild pulmonary stenosis, they are less sinus and they don't need PDA. Okay, so what happened? when they are in exertion or when there's a reduction in venous return. Okay, actually vasa maneuver increase venous return. Dia in other, for example, exertion lah, in exertion, atau when your heart is pumping fast, when you are tachycardic kan, exertion tachycardic. So what happen is there will be reduced flow to the pulmonary. Okay, so there will be like an increase of suction. The obstruction sama, tapi because of reduced flow to the pulmonary, reduced blood, cardiac output reduced because when your heart is fast, okay, there'll be less blood come out from the right side, from the heart. Sangat laju sangat kan, heart there's not enough time to feeling kan, to feeling during the diastolic kan, kita akan feel kan, ventricular feeling. When there's too rapid heart rate, so not enough time for ventricular filling, so less blood come out through the pulmonary valve. So you've got a critical pulmonary stenosis at that time. That's why you become sinus. So what to do? Okay. What to do? So apa yang kena buat? You kena relaxkan the child kan. So that's why the first step is, kalau patient datang dengan TED spell, try to avoid poking the child. Kalau nak poke, kena orang yang betul-betul memang kena ask your MO or specialist lah, yang sekali cocok you boleh dapat the venous access. Don't make the child cry because it worsen the TED spell. So calm the child. Okay, suruh mak dia calm the child. That's the first step. Second step is you increase the venous return. Kan? How to increase venous return? In adult kan, macam kita nak increase venous return?
Squatting position.
Squatting kan? Squatting is actually Vasava maneuver. It's similar to Vasava maneuver. Okay. When you squat, you are actually creating a Vasava maneuver. You increase the Vasava maneuver ni is actually you are increasing the intra-abdominal pressure. So that you promotes venous return. Okay, faham? Ataupun you reduce the intrathoracic pressure kan? Macam mana you reduce intrathoracic pressure? Macam you nak reduce intrathoracic pressure?
Inhale deeply.
Inhale apa dia?
Inhale deeply.
Inhale deeply Inhale ke exhale yang reduce intrathoracic
Exhale
pressure?
again, close vocal cord.
Exhale kan? Exhale actually yang when you exhale, so you reduce the intrathoracic pressure. Faham tak? At the end of exhalation has the lowest intrathoracic pressure lah, barulah air masuk. Kan? Ya. Betul lah. You exhale against block ni kan. Okay, so tu lah nama dia. So Vasava maneuver, relax the baby, Vasava maneuver. Okay, what other else you can do? You boleh bagi dia bolus kan. You nak increase venous return, you nak naikkan banyak darah, you nak tambahkan darah dia. So you buat apa? Bagi bolus. So if these two measures not effective, kan, you just relax baby, tak berkesan. So you squat the baby, dudukkan dia ataupun baringkan dia, you squat the kaki kan. Angkat kaki ni atas ataupun squat dia supaya increase venous return to the blood, to the heart. Kalau tak jadi, you bagi dia bolus. So bagi dia up to 20 ml per kilo normal saline. Bagi bolus. Okay. If bolus not working, sometimes you boleh bagi up to 40 pun. Because they need a lot of volume. Okay. If bolus tak berkesan, then you have to do other measures. Okay, what measures you can do? You have to intervene lah. Okay, things like, okay, you can give morphine. Okay, give morphine to relaxkan patient. Okay, actually morphine, we don't know how morphine works, but most likely through relaxation of the vessel. Kita tahu morphine receptor are present dekat pulmonary vasculature. So it relax the vasculature lah. Itu satu, and then it's also relax the baby. So you bagi morphine, they relax, so heart rate drop, so better. Besides that kan, bila you ada tachycardic, you tahu Bernoulli principle tak? It's quite complicated. Ini I kena lukis lah. Tapi maybe later lah kalau kita jumpa, maybe you can ask me about. It's similar to Hockham tau. It's similar to Hockham. It's quite similar to Hockham. because we are talking about outflow, right and left outflow. Hokum dia occur dekat left outflow, so patient sudden death. Okay, in that spell, the similar mechanism occur in the right outflow, so they become hypercyanotic. It's very similar. If you understand this, you will understand Hokum. Okay, Hokum, both Hokum in adult and Hokum in pediatric, in congenital. Hokum dengan acquired Hokum, and also the congenital Hokum. Okay, anyway, so kalau morphine tak berkesan, then you give propofol, you give beta blocker. Why? Because you want to reduce the heart rate. Okay, in general, you give beta blocker to reduce heart rate lah. That's one of the principle. Even though actually we don't know how beta blocker works, but most likely is by reducing the heart rate, you reduce the effect of Bernoulli principle. Nanti you baca Bernoulli principle is apa. Kalau you tak ingat lah, you baca what is Bernoulli principle, and then try to make sense. Kalau tak make sense, then maybe later you boleh jumpa I boleh explain through diagram lah. And then kalau propofol tak berkesan, then the last one is you bagi adrenaline. You give adrenaline, bolus, and then followed by continuous infusion. Okay, but usually kalau propofol tak works, adrenaline susah nak works usually. Usually adrenaline susah nak works. Okay, and if adrenaline not working, adrenaline biasa akan berkesan lah, tapi it won't resolve the attack spell fully. So you have to prepare emergency surgical repair. Okay, this will be in terms of in the form of palliative surgery lah. Which is kalau ni baby yang newborn baby atau baby neonatal period yang still ada PDA, then you have to stand the PDA. Okay, you kena buat PDA stenting. Kalau ni budak yang dah besar, yang PDA dah close, not doctor dependent, then you have to create a BT shunt, urgent BT shunt. Okay, faham tak? Okay. So the indication untuk operation for patient with TOF kan, we usually operate after the child more than 10 kilo. Okay, most of the time umur biasanya dah 3-4 tahun lah biasanya. Unless kalau dia ada severe attack spell. That is the only indication untuk corrective surgery in patient with TOF. So when you follow up patient with TOF, one of the questions you have to ask mother, is there any attack spell? And is there a frequent attack spell? Kalau dia ada occasion ada attack spell and then resolved by conventional conservative punya treatment, then it's okay lah. Tapi kalau tak resolve, prolonged attack spell atau very frequent attack spell, then it's a time to operate. Itulah tu lah. Okay, silakan ada soalan?
Thank you, Doctor. I have no question.
Okay. Okay, rasanya kita boleh rest dulu. Then continue dengan rest for 30 minutes. 30 minutes.
Sorry, Doctor?
Boleh rest for 30 minutes ke? Macam tak clear.
Kurang clear.
Sekejap. Kalau kita rest for 30 minutes, okay?
Okay, Doktor.
Okay, 30 minutes lah. So, terjumpa balik pukul 9. 25 minutes lah. Pukul 9 terjumpa balik. So, siapa present? Pukul 10. Sorry, pukul 10. Siapa yang present ni?
Anissa.
Okay, Anissa, you prepare your presentation. Because you year 5, so I expect you present from A sampai Z. From presenting complaint sampai ni, without mentioning the ni lah. Ke selalu you presenting complaint is the history of presenting complaint ni ke, atau you just present sampai habis? Selalunya kat sini. So you present components by components ke, atau you present A sampai Z? Selalunya lah.
Maksud doktor macam mana?
Maksud dia macam history of presenting complaint, okay, patient blah 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 blah, family history, patient blah blah blah, ke ataupun you just present?
Tak sebut pun, tak mention pun the heading tu. Just
okay.
go through the history.
Okay, so just go through the history, and then everyone kita tak akan stop sampai habis. So I want everyone to jot down what is good, okay, what is good about the presentation, and I nak you guys dengar carefully what is good, and I need the quote. I need you to quote from the presentation. Contoh, you kata, Okay, Anissa present the history of presenting complaint in great detail. Okay, for example, she mentioned she described the fever as is intermittent fever, relapse remitting with highest temperature of blah 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 blah. Macam tu. Okay, everyone have to at least 2 or 3 good about the presentation, and then you have to find at least 2 to 3 things that can be done better, and then we give feedback at the end. Okay.
Doctor, before that I will be clocking you first, right? Or
Itu buat clucking ni Aku tak present. Okay,
macam
tak
role
apa.
play.
Okay, you nak buat cardiac kan? Sorry, I lupa lah. Okay, boleh. If that's the case, you clock me first. Okay, everyone listen how she clock. Okay. So clucking dah berapa minit lah selalunya?
Actually kalau with Prof from one side usually 20 minutes kan? 20 minutes kan? Around 20 minutes.
Okay, so we do 20-minute clucking. Okay, we do 20-minute clucking, and then I give you time like 10 minutes for all of us. To think what went bad, what went well, what went not so well, what can be done better, and then you present the case, and then we give feedback. Presentation dah 10 minit Macam mana? Presentation 5 minutes ke less than that? Usually kalau you guys present, dalam 20 minutes. Present dalam?
Presentation usually 30 minutes with discussion. 30
Okay,
minutes.
so present 5 minutes, 25-minute discussion lah. Okay. So we meet back insyaAllah at 10. Okay. So yang ni biar je lah kat sini.
Doktor.
Nak stop recording dulu ke ataupun nak biar je? Kan you guys chatting kan kena ada orang complain lah.
Boleh pause
Tak dulu ke
recording, Doctor?
Pause dulu. Okay, Aklan pause dulu.
Tapi recording ni by department.
Yang
Kalau leave dulu pun tak leave dulu.
Boleh ke masuk balik? Okay kan, boleh. Left dulu lah.
Thank you, Doctor.
Okay, welcome. Assalamualaikum.
Salam.